we go. Hi, everyone, and welcome to our Connected Kinesiologist meetup for Monday, June the 7th. I'm Angela Pereira, the founder of First Line Education and a co-administrator in the Connected Kins group with Rebecca Adaman, who is doing her PhD in knowledge translation at McGill. And I'd like to introduce both Bridget Ribot and Andrea Cavalier. And they are joining me to talk this evening about acquired brain injury and concussion. And what I'd like to do is have each of them introduce themselves, and then we'll introduce or have the other people in the group introduce themselves, and then we're off to the races. So I'll just turn it over to Bridget to say hello.
Hello, I'm Bridget. I'm a registered kinesiologist, and I'm currently working in a functional neurology and vestibular clinic in Burlington, where we support patients with a variety of conditions from ADHD, Parkinson's, stroke, brain injuries, post-concussion syndrome. And for the last couple of years, I've also been working at a neurobehavioral unit within Hamilton Health Sciences at the Regional Rehab Center, supporting patients who have acquired brain injuries and other mental health conditions.
Wow, definite niche.
Very.
And over to you, Andrea.
Hi guys, I'm Andrea. I got my master's from York in kinesiology, and I did a graduate diploma along with it in neuroscience. Afterwards, I was a personal trainer for a couple of years, and then COVID hit, and then I became a registered kinesiologist, so I'm legally allowed to work. And then with that, I got a job offer from Lifemark Rehab, which is one of the biggest physio chains in Canada. And right now I'm the kin lead for the WSIB owned program at the clinic. So, you know, workers that got hurt at work, they come see us specifically if they got, you know, if it's a head or neck injury, which is, you know, concussion related. I usually be their primary therapist, you know, relaying all the information I learned to the hospitals, to our clinic, and then of course, prescribing education. And I work part-time at Provision Sports Performance at Chestwood Arena. There, well, not right now, but when there's athletes there, I'll be performing baseline concussion testing and, you know, some rehab work if it comes to that. You know, we hope they don't get hit, but that's always not the case.
You're
So,
ready
yeah.
if you do.
Exactly, yeah.
Very cool, very cool. All right, I'm going to flip this over to Xana to say hello. Can you tell us a little bit about what you're up to?
Hello, my name is Xana Olette. I'm a registered kinesiologist in Windsor, Ontario. I also work in the OWN workers program, primarily in the neurology program in occupational rehab.
Cool. So this is also going to be super relevant for you as well. That's great. Mackenzie, hello. You want to say hi to everybody? Hi.
Yeah, sure. So I am also a registered kinesiologist. I'm currently working in Brantford, Ontario. They mainly focus in kind of recreational therapy, kind of respite day programming, but there's a kinesiologist kind of section there, me and another kin, and we provide kind of individualized exercise to older adult population. We see patients or clients with MS, post-stroke, Parkinson's, different areas like that. So the kind of brain injury side of things is really interesting and has been really eye-opening for me and starting in this role. So yeah.
Very cool, very cool. And this is new for you, is it? When did you start working with this group?
So I've been there for almost 3 months now. So it's
right.
Cool. Yeah.
Wow. Okay. Interesting. So this will be great for you as well. That's super. Sabrina, hello. How are you?
Hi, I'm Sabrina. I was a kin in Quebec, moved to Ontario, and I'm just waiting to write the exam in Ontario. Yeah, I thought I'd hop on the call and see what they have to say about the topic. Bridget is my twin sister, so I thought I'd see what the presentation's gonna be and what they're gonna say. So yeah, for now I work as an educational programs coordinator in skin health, but yeah, looking to kind of just expand on my knowledge. So yeah.
Oh, interesting. I couldn't remember if you two were cousins or sisters. So there you go.
Yep.
Very
Twins.
cool. Even better, even better. Carrie, hello. Are you able to say hi, or are you otherwise occupied? And if you are, not a problem. Oh, there you are.
I am just hopping in my car from my last client.
Oh,
So,
awesome. Good for you.
Yeah. So we're just doing introductions. Is that
Yep.
where we're at?
Yep, we are.
So, perfect. So my name is Carrie Dahl. I'm a kinesiologist in Kitchener-Waterloo, Ontario. I mostly work with seniors doing senior wellness as well as neuro rehab, so stroke. I have a few, I guess, legacy concussion clients. So that's why I'm hopping on the call today. So I want to learn as much as I possibly can about concussions, TBIs, things like that. And yeah, so I'm also mobile. So that's why I'm in my car.
Awesome. Amazing. And I want to ask you, what does legacy concussion mean? I haven't heard that term before.
That's kind of a new term for me too. I was just on in the concussion rehab lab boot camp. I think it was posted in here. I forget who shared it. But that was the term that she was using for concussion for people who have a history of concussions that still experience, I guess, symptoms from it. So it's kind of like post-concussion syndrome.
Right. Oh, okay. Okay. Interesting. Yeah, I hadn't heard that term either. So that's neat. Oh,
Yeah.
So our plan for, thanks, Carrie. Our plan for this evening is that Bridget's prepared a brief slide deck for us just to walk us through a little bit more about the history of concussion and ABIs. And we thought we would just casually chat through the slides and see where that conversation takes us. So I'm just going to pass this over to you, Bridget. Go right ahead now. Are you
Sounds
able?
good.
I think you can share the screen all right. Yep, you should be okay.
Looks like I should be able to. Perfect. Let's see, I'll get in here. It should let me here. Can you guys see it all right?
Yep.
Yeah.
Okay, perfect.
Thanks.
So like Angela said, at any point, if anyone has any questions or just comments they want to jump in, feel free, just pop in and we'll have a little chat about it. So to start off, this is a little outline for today. We're going to define concussions and ABIs. We'll go over the return to play and return to work guidelines. We'll talk a bit about the importance of having a multidisciplinary approach to concussion rehab, as well as go over different rehab strategies within that KINs can use specifically. A couple of key things to keep in mind when you're working with ABI or concussion population, as well as some further education options you can look into to become more specialized when working with this kind of population. So let's see. So we'll start off by defining concussions and acquired brain injuries. So the main difference is that a concussion is a functional disturbance, whereas an acquired brain injury is a structural damage to the brain tissue. So the functional disturbance in concussion is caused by the stretching or shearing following an impact to the head, neck, or body that causes the head to move around on the head, or on the neck rather. It doesn't cause any physical brain damage. It's the most recent research is showing that it's more of an energy crisis is what they're calling it. And not to get too nerdy with it, but essentially it's energy crisis on a couple of levels. The potassium, calcium pumps, if you remember that from school way back when, there's a disturbance in that requiring more energy to make those pumps work. And on the flip side of that, there's also the calcium channels themselves also need more energy because they flood into the cell and more energy needs to be used to get them out. And they also impact ATP production. So it's energy crisis on a whole bunch of levels on like a cellular level, and that leads to less energy overall, which causes the rest of the symptoms of concussions, depending on what areas of the brain are affected by the shearing and stretching that happens inside the brain tissue. An ABI is caused by similar things to concussions. So a jolt, bump to the head or body. Usually with brain injury though, the head has to be hit a little bit. there's two ways that ABI has been broken down into traumatic brain injuries, so what people call TBIs, or non-traumatic brain injuries. So an example of traumatic brain injuries, the main three are motor vehicle accidents, sports, and falls. Assaults also fall into that. Accidents during brain surgery also fall into traumatic brain injuries. And on the flip side, we have non-traumatic brain injuries. These are things such as strokes, tumors, infections that go into the brain and hurt tissue, and also substance abuse, overdoses. They also cause brain injuries as well. The impairments with acquired brain injuries are often permanent, whereas concussions, usually people recover within a month, give or take. And the damage is not permanent to concussions, but the damage is often, unfortunately, permanent with ABIs. So signs and symptoms of concussions. So pretty well anything that your brain can do can be affected by a concussion, which is pretty well everything you do in your day-to-day. So anything that has to do with thinking, remembering, so cognitive tasks. There's a bunch of physical symptoms people usually think of, such as headaches, head pressure, dizziness. Those are all physical symptoms you get. There's a lot of emotional symptoms that come along with concussions and brain injuries. So people become more irritable. They might have some aggression they didn't have before. They might just start crying or laughing uncontrollably and they don't know why. There's also sleep concerns, whether it's people are sleeping too much or they can't fall asleep or they're not staying asleep. Sleep is a huge part of concussion rehab, especially because if you don't have good sleep, your body doesn't have that chance to repair and heal itself. So it's a bit of a double-edged sword with concussion healing. And then should also touch on some red flags for concussions. There's a couple of red flags that could indicate greater damage. So for concussions, these things could indicate the possibility of having a true ABI instead of just a concussion. So there are some things such as if you have decreased alertness, if you have slurred speech, if you have blurred vision, or if you have uncontrolled vomiting or vomiting that happens more than right after the initial impact of the injury. So we have concussion rehab, quite a broad scope of how concussion rehab works. So I'll kind of get into it a little bit more, and Andrea, feel free to jump in whenever you like as far as concussion rehab goes here. A multidisciplinary approach is the best way to handle a concussion. As I put there, teamwork makes the dream work, and it really does when it comes to concussions, because given the vast array of symptoms that concussions can have and can lead to, it makes the most sense that you would have a team that helps specialize in each of these parts. That way the athlete, patient, whomever it is you're working with has the best chance of coming back from their injury. So some examples of healthcare professionals that you can liaise with. There's doctors, psychologists are really big. About 50% of people who have acquired brain injuries end up with depression, very least, if not other forms of anxiety. Around getting re-injured is a big one for concussion athletes as well. So working with a psychologist or some kind of psychotherapist is really important for athletes if they are trying to return to sport from, especially if they've had multiple concussions. That's a big one. Other people would be speech language pathologists, especially good for ABIs because oftentimes swallowing or speech difficulties can become a long-term part of their life they'll have to learn to work with. So having someone who's trained in that is the best way to go. There's also behavior therapists. As I mentioned with ABIs especially, concussions is as well, but especially with ABI in my experience, there's often behaviors that come along with it. So whether it's they're more agitated, they might be physically aggressive, they might have verbal aggression, they might have restlessness, and it's good if you have someone part of your care team who is specialized in helping them work through whatever behavioral concerns they might have following their injury.
So Bridget, just a quick question for you. Yeah. I'm trying to look at the differences between the role of a psychologist and the role of a behavior therapist. And my take here is that perhaps a psychologist would want to get underneath or behind the thought patterns, perhaps, or the processing patterns, and kind of draw people's attention to their different moods or emotions and how those are expressed, whereas the behavior therapist may be working more with almost like practical on-the-ground tools for coping.
Absolutely. go about
Okay.
it well. And in with psychologists, you can also kind of put psychiatry as far as in case medications have to come into it. But for psychologists, a lot of the counseling would be really helpful for a lot of people who have concussions or ABIs. It'll just help them come to terms with how their life might have changed or what tools they can use to get back to it. And behavior therapists are, like you said, more so like the on the ground tools, like what strategies, how's their day plan out? How can we rearrange their schedule to make sure that it's in line with their own energy needs of if they need to take naps, how can we plan their day around this stuff? That way they don't escalate and have outbursts coming up. Yeah, great point. Another good one is massage therapy. This one falls also along with some stuff that KINS can do, as well as some stuff that physiotherapists can do as well, as far as working on the head and neck. A lot of patients who have concussions, they also have whiplash injuries because it's nearly impossible to get your head to move around without having some neck strain come along with it. So it's really important that you have someone who's able to work on their neck if they do have some residual stiffness, just to reduce any headaches that might be coming from some suboccipital tightness at the back.
I also think that massage therapists and KINS would be helpful looking at that remedial or corrective exercise piece to kind of downgrade the nervous system to shift people out of that flight, fight, or freeze situation and sort of help people to realize what their body is kind of somatically trying to convey so that they're able to recognize signs of increased tension, as you mentioned, and try to see if they can, first of all, recognize that and mediate it, and which
Absolutely.
will help them to manage their behavior and their function.
Yeah, absolutely. That's a great place for KINS to be as far as the musculoskeletal side of concussions or ABIs as well, which is a bunch. And I'll go over it, I think, one of the next slides about the more specific stuff that KINS, as far as physical work they can do to help this kind of population. And just the last two I want to touch on here is the occupational therapy part. With concussions, hopefully people get back to their life before and we are able to treat them within the first month so they have a greater likelihood of getting back to their life. But in the event that doesn't happen right away or it just isn't working for them, occupational therapy is a really good resource to use for have tools as far as relearning how to read and follow like lines on a page to help with some attention, to help with different tips and tricks to schedule your day, kind of like behavior therapist I was mentioning, to really schedule your day, make sure that everything can happen as you need it to, make sure that you have the right supports when you need them, especially if you have a more severe kind of ABI, you'll need to schedule having like PSWs, make sure they're there, make sure loved ones are all trained on how to transfer them in and out of bed, toileting, showering, all that kind of stuff, make sure that everyone's in their life is able to support the person as much as they need for ABIs especially. And the last one is dietitian. There's a lot of good new research coming out about diet and its effect on concussions. And some dietitians are becoming more specialized with helping people who have neurological conditions. And they're a good piece to reference if you think that, you know, your clients tried sleep and their sleep seems like it's fine. They've tried physiotherapy and physiotherapy's fine. They've been working with you to fill in all the gaps they didn't get from the years prior to whatnot. Dietitian might be a good person to throw in there to see if they've can find anything as far as gut brain health that might help, or just like a healthy brain diet. Okay, so this is a little timeline of the return to play, return to work. It's very bare bones. There's a lot of variance within this, but essentially off the bat, there is within the first 24 to 48 hours is rest time. So your brain has had this whole exciting thing happen and you need to let it rest. Try to really cut out as much as you can. So if you try to put your phone down, don't watch TV, don't read your book. You know, if you go to work, well, you really shouldn't go to work if you just had a concussion. I would definitely not do that, but don't go to work for the first 2 days, very least. Don't go to school. You might really want to try to exercise. Give it at least a day or two for your body to fully rest and have that time to try to kickstart that recovery process. Because if not, that's when you really get into the things like post-concussion syndrome, like the legacy concussions, which I was on a bit of that call too, Carrie. And I really love that term because it's really encompasses well the people who had concussions years and years ago, but they still feel the effects of them, whether it's been like 5, 10 decades later, they still might have some residual effects. So really getting that rest in the first 1 to 2 days is where a lot of these can be avoided in the first place. So during this time too, it's important that you rule out anything that could be more severe happening. So whether that be getting CT scans, MRIs, if you're able to, just to make sure that the patient doesn't have anything worse. Doesn't hurt to get their vision checked if you think they might have vision issues, that kind of stuff, just to really rule out nothing more structural has happened if you do suspect they have a concussion. So that next point, after the first couple days of rest, you want to start doing daily activities. And everything on here, you want to do it up to symptom tolerance. So you don't want to do it to anything that's going to increase your symptoms more than they already are. So daily activities, you could make some food. You might be able to go for a short 5-minute walk. It's more like house chores and that kind of stuff. You can kind of do super duper low, very, very low, like cardio. Not, I want to say cardio, but like low energy activities you're able to do.
Yeah.
After this,
Sorry.
No, go ahead.
And to kind of snowball on that, I think we'll talk about this later, about pain. And she does make a good point. You don't want it to cause too much pain and symptoms, but at the same time, you don't want to avoid it. And that's probably what, years ago, decades ago, my brother used to get a concussion in soccer, and the doctor prescribed at least 2 weeks of bed rest. But now we know that's detrimental. So, when we talk about pain and rest, the body adapts and it can maladapt. So if you take away stimulus, it'll get used to that. Like if you have light sensitivity, putting your sunglasses on all day is maladaptive. It's not going to help you. Your brain is never going to recover from that. So we always want to not push the gun, but kind of push the line every week. So like she said, like if you're doing 10 minutes of Instagramming, that's your limit, cool. But then next week you can try 15. So it's all like a spectrum, and it's all like longitudinal in the long run. But the one thing you don't want to do is avoid symptoms, because they will happen. So that's one thing to consider in this whole spectrum.
It's so interesting because you're looking at kind of low dose exposure, and
Exactly.
it's such a challenging thing that turns up time and time again for all of our clients in many different ways. So again, that pain threshold that you were talking about, or people experiencing nausea and dizziness, trying to expose them to those symptoms gently so that their brain and body realizes nothing terrible is going to happen, but we do need to expose you to these things so that your body and your mind actually have a chance to deal with them, to actually learn how to adapt to them.
Yeah, that's why in clinics such as OTs are super important, because some people are scared to go back to work because the sounds, the lighting, the interactions are painful. So it's good to have that education, just like right now what we're having. The education almost helps in that whole therapy. So we don't want them to be like maladaptive and all that.
For sure. Yeah, I couldn't agree more. And I was part of that initial, back when I had my own concussions in 2014 was the bulk of them. I was part of that dark room basement group, and I really didn't do much for several weeks, if not months. And it took me close to 5 years to really be more or less symptom free. And that was, looking back now, is entirely because off the bat, I was told to do nothing for a long time until I had no symptoms. And I wish I knew then what I know now about it's okay to do a little bit of exercise. If it brings on a little bit of symptoms, don't go crazy with your symptoms. But if the symptoms are there, you can still do stuff. Just don't make the symptoms worse while you're trying to work through it, because you really have to get your body used to the fact that it has to start doing stuff again eventually. So, yeah.
So that's really interesting. Both of you acknowledging this kind of low dose exposure and moving slowly into those adaptive behaviors and making sure they don't become maladaptive. you have a reference here to doctor/NP check clearance. So would you say that doctors, and is it naturopathic practitioners? What does your NP?
I put nurse practitioner, sorry, for because they're the ones who are able to do diagnoses and clearances. They're the two who are formally allowed to clear people through the steps. So for this format here, essentially, once you have your couple days of rest and you're able to do some activities without having a giant increase in symptoms, you're supposed to get clearance from your doctor or nurse, whomever you're working with, to move on to the next step of actually doing some more cardio and a little bit more like heart increasing activities.
So that's interesting. So are all physicians and nurse practitioners educated about being that first job? Because I was thinking as a potential concussion experiencer, would I go to Emerge? Would I call my family physician? Would I send them a note to say, this just happened, what do I do? Who would be my first point of contact? Would it be a physiotherapist or a kinesiologist that I regularly worked with who would then advise me to do X, Y, and Z? What would that look like?
Well, I guess it depends on the context of injury. If you're in the rink and you just got body checked, usually the onus would have to be on the athletic trainer, whatever medical staff is there. Right? So if it's workplace hazard that occurred, it could be, some places have nurses, but most don't. So it depends on the context, and it goes back to education, right? But when in doubt, always refer out. So if you're not sure of the red flags, which are vital, always refer out. But I think we'll get to this point later. Whatever happens, we need to start the process right away. So from day one, we have, diagnoses. If we need to go to the hospital, get those scans. If we notice a skull fracture, if we notice vomiting, seizures, get that CT scan because we want to see if there's internal bleeding in the brain. If not, then we need to go right away to, secondary therapists or secondary healthcare, which would be kinesiologists, physios, chiros, all that, just to start the process right away, because we have such a small window, which is like a week. And if we kind of surpass that week, recovery is, it's just slower. So that's why we see a lot of like PCS, clientele coming in, because they kind of, take too long to get to the clinic.
And what does PCS mean?
Post-concussion syndrome.
Got it. Yeah. Well, thanks for clarifying that, because I always wondered if you're an athlete, if you were someone doing a job at home, if you were in a car accident, are there people who would know, okay, let's quickly screen for a concussion? So I'm not sure that everyone who's involved in a car accident where there was an impact at a certain speed would then be referred, or someone who notices symptoms within that 24 to 48 hours would then be referred. So that would be one of the questions. The bigger questions I would have is, you're right, how do we educate not only primary and secondary healthcare practitioners, but also the general public to say, watch out for these things. So Elise just has a comment here. All figure skating coaches have to take a concussion workshop, and they have to get the student to get clearance from a doctor before returning to the ice. Yeah, right. And I'm sorry, Xana, I missed this comment that you'd made. Even many neurologists are not up to date on ABI concussion research. Wow, so it is a real niche. And it looks like, to Elise's point, if you are in a coaching or athletic therapy, athletic trainer role, you're probably up to speed on concussion, or you should be up to speed on concussion protocol. Right? Yeah.
Especially at York, where the kinesiology department in the neurovisual sciences, a good chunk of it is connected to the athletic therapy department. So it's like they're really well versed in like TBI, so it's really, really good. But like she said, there's some doctors may not know. They just do a neurological exam and that's it.
Right, which we know is KINs are going to be looking at major reflex pathways, which
Yes.
may not be subtle enough to be picking up these symptoms, because usually the way we teach it is you're doing those neurological screens if you're noticing typically kind of some late stage issues popping up for the most part.
Yeah.
Yeah.
Mhm.
Not the subtle
Yeah.
ones that you might see with concussion.
Yeah, and that's a big thing, as far as trying to get more doctors, and really just doctors are the biggest people because they're the ones who have to do the clearance, and they have to be educated on what the symptoms are and what the best plan of action is and what the up-to-date information is, because a lot aren't. And even at the clinic I now work at, we've had a couple patients come in who've gotten concussed in the last year or so, and some of them still have doctors who tell them to go to that dark room, and that's still their game plan. And the research has been out for at least 5 years now, saying that that dark room isn't the way to go, but there's still that gap between the research and what some people are doing clinically and what has to spread to the rest of the ER docs are getting better at it, but a lot of GPs still don't. They just don't know, and they don't know the updated information. So they're going to end up negatively affecting their patients' outcomes, at least their short-term outcome for sure, for a little bit.
Right. And I think that for most people, if their symptoms aren't particularly severe, they'll go to their GP in a day or two, let's say, rather than saying, you know what, I'm just going to go to Emerge and get myself screened. And
Yep.
if I get myself screened and I need or I don't need a CAT scan or an MRI, at least it's not me making that decision for myself. I'm putting myself in front of someone who can do that screening for me and say, you're fine, your symptoms are not to the point where we would order a CT or an MRI, or, you know what, let's just do it anyway. So we get a baseline for you, and then that way we can monitor your symptoms from there.
For sure. Absolutely. Like even with my own concussion was now 7 years ago, at least I've had several, but the biggest one. And it was on a Friday afternoon at rugby. So my own doctor was closed. So I went to I went to the walk-in clinic the next day. And the only test the doctor did with me is he had me hold both arms out, close my eyes, counted to 30. And as an athlete, I passed that with flying colors. And he said, nope, you don't have a concussion. You just have a bruise. Your hematomas might turn into a black eye. You're good to go. And
Wow.
I knew better then. So I went to my doctor the week later and got a proper checkout. He said, no, you're not actually good. And he referred me to a sports medicine doctor at that point. But the walk-in clinic doctor, his only test was hands up. Nah, you're okay. Out you go. So I'd like to think it's getting better than that. But I've seen patients in the last bit, and I've heard of friends going to their doctors and having similar results, saying, no, you're actually fine, but they're not actually okay.
Oh,
Yeah.
interesting. Wow. Well, thank you for that sidestep.
What do we have next here? So similar to what we've been talking about, the slowly increasing your activity levels, you want to start with, they say about 5 or 10 minutes of walking, nothing more. Don't try to start jogging off the bat, because you really want to keep that heart rate down, because you want to make sure that your body's able to, and your brain's able to tolerate the increase in heart rate. So start with walking, and after you can get up to 20, 25, 30 minutes of walking, no problem. At that point, you can try to increase your exercise tolerance. So once you can walk, no problem, you can start increasing your exercise. You want to start with just running and basic drills on your own without other teammates around. And then once you can do some more cardio and some more sport specific drills, if you're trying to get back to work, you might be able to start doing some work at home. They might not have you go back into the workplace just yet, because they want to make sure you're able to at least do some cognitive tasking at home before you get back into your work or into whatever life you have going on. They want to make sure you're set up for that. After this point, if you still don't have increase in symptoms and you're able to do some more cardio, you're able to do some work at home, you're able to use your computer for longer than 5 minutes at a time, the doctor / nurse practitioner, whomever it is that you're working with to get clearance from, they give you clearance. And at that point, once you have your final clearance that, yes, I can do exercise, yes, I can read books, I can use my computer screen, I can stand up for several hours a day to get back to work. At that point, you can get back to your regular activities. So you can start having contact practices Once you're good with contact practices, then you can move on to game situations. Same, the return to work protocol is similar in its graduation in that depending on the workplace and how they have it set up, you might start with half days, you might just do 4 hours at a time, then you might move up to 6-hour shifts, or they might have a bunch of 4-hour shifts, and then you have one day where you have 6 hours or 8 hours of the day, just to trial that with a lower standard the rest of the time.
That's really interesting. So Bridget and Andrea, how long would you say that this process would typically take from that 48-hour point onward? Is it just per person, or is there, it should take you about a week to 10 days? What are we looking at for a timeline there?
Oof, I mean,
They say at least go 24 to 48 hours between steps to make sure symptoms aren't delayed, because oftentimes with concussions, you'll do something in the morning and you're like, wow, this is great. I'm going to go for a jog today. And you go for a jog and you're like, oh, I still feel okay. And then around dinner time, you start like, whoa, maybe I'm not actually okay. And you really need to give yourself that 24-hour window minimum to make sure that, yeah, I am okay. My body can tolerate this. I'm ready to move on. The return to work part really depends on how long you've been off. If you're experiencing some like real, not severe, but if you have post-concussion syndrome and it is going on for a little bit, each step between graduation, it could just be weeks if you're feeling good. It could be 2 weeks. It could be a month at each stage. It's really just up until your tolerance, and that it's really just individualized to the person's tolerance.
Mm-hmm. Exactly. Exactly what she said. It's highly variable. And she talked about that metabolic cascade atomic bomb happening in your brain. And like you have like you have a sugar going all over the place, you have calcium going all over the place. And we see in rat studies, because that's the best we can do right now, that usually that the fallout tends to clear after like 7-10 days.
Wow.
So for humans, it's around like 12-14 days. So that's
bigger
like
brains.
Exactly, yeah. So
but for most
but
of us, bigger brains,
yeah. So typically for acute concussion, if I were to handle that, I would return the person to play or work, typically after at least a month. It could be longer than that. I would definitely not bring them earlier than that. But like everyone's different, but I definitely want to make sure they're outside of that window, because if you do get another impact, right, within like that 2-week period, that you may not be neurologically better, neurobiologically better than that, then it could be additive. Right?
Oh,
so it could be
there's
like
a cumulative effect as you add more time.
It could be very cumulative. So as therapists, you have to be careful, but also like prepare for the worst. So you actually want more time instead of like just shooting them out into the rink or shooting them into the construction zone. So you have to be like, don't have cookie cutter programs, but at the same time, you have to be individualistic too.
It's tough when you're designing a treatment plan for an employer or an insurer, right? Because you're keeping these general rules, quote unquote, these timelines in mind, but there's such variability. And I can imagine there's variability according to age, athletic or work experience, what the person's mental health was like beforehand. And as you mentioned, what their nutritional status is, their sleep status is, all of these confounding or potentially confounding factors that will really influence that timeline. And you may not be aware of how those factors would impact someone when you overlay a concussion or an acquired brain injury on top of what they're normally dealing with as a physiological or neurological load.
Yeah.
Mm-hmm.
And there's some research coming out as of late as well, like you mentioned, their mental state beforehand, that if you have some kind of mental condition, be it depression, anxiety, if you have ADHD, those symptoms are usually amplified, and they also, unfortunately, very high percentage will increase your length of recovery if you go into the concussion already with these conditions.
Makes a lot of sense, And to that point, having a dietitian or a nutritionist work alongside these other professionals to optimize gut health and trying to
Yes.
maximize then the knock-on effect of brain health would be really
Yeah.
critical in that healing process. And from my experience going through a couple of years of nutrition school, this was not discussed in nutrition school. So very,
No.
very interesting.
Yeah.
And I'll ask
Yeah.
some dietitians I know whether or not they cover
Yeah.
this in school, or whether it's, continuing education. That's very interesting to me.
Yeah.
It's definitely a new thing within like naturopaths.
Mhm.
Like some people call them quacks, but they have a lot of good research going. But
Oh,
the one
yes,
thing
they
that
do.
oh yeah, one thing that they're really honed on it was the leaky gut. And
Yes.
once you got concussion, you have a lot of autonomic and neurological issues. And we do know that most of the
Nerve
nerves
system.
kind
Yeah.
of end up in the gut. And then you have this whole cascade of weirdness going on, like sugar, anything processed just makes that gut worse. And the vagus nerve sends off autonomic crises, and it's just a whole, like, we don't have enough time to talk about the vagus nerve and, and leaky gut,
Beautiful
but
storm, isn't it? Yeah, for
Yeah.
it's
sure.
a huge storm. Yeah.
Yeah.
So
While we're, oh, go ahead.
no.
No, I was gonna say, while we're on the topic of kind of things that can, like, pre-existing conditions that can affect concussion outcomes, there's been some research as of late that came out as well, as far as women and like what part of their menstruation cycle they're in, and how that can negatively affect their outcome concussion. So if they're in the luteal phase of their cycle at the time of their concussion, it can both increase the risk of you actually sustaining a concussion, but also if you do get a concussion, it's likely that your recovery will be longer, which I'm not sure how clinically you can control for that as a female athlete. Like if you're playing, you're playing, or if you're at work and you have an accident, you can't control for it. But it'd be something that's good to know when you're treating them, if just to have a better estimate of a timeline for when they might recover, if you know it's going to be a little bit longer than what it would be otherwise had it been a different part of their cycle.
So interesting, right? And I think that's something that as therapists, we need to be asking our clients, how, the menstrual history.
Yeah.
I think that's pretty critical. So this kind of leads to the next question that I had was, once someone is seeing their physician of whatever background, or their nurse practitioner, and there's a clearance that happens, or there isn't a clearance, so there is a diagnosis made, let's say, does the doctor or the nurse practitioner then start to direct the rehabilitation process, or do they step back and say, who do you have on your team? We will convey the diagnosis to them, and then whether it's a psychologist, a psychiatrist, whomever else it might be, does someone else then become kind of a case manager and start taking over that rehab process and the treatment planning?
It really depends on how, I don't want to say how good your doctor and nurse practitioner is, but essentially how knowledgeable they are in concussion care, and if they're able to see the symptoms they have existing and be able to refer them out to other people. A lot of them don't know what to do, or they just don't know they have to do anything. So they just say, yeah, you still have a concussion. And that's it. Whereas some of them will say, okay, you still have a concussion, and your mood's getting kind of low. And I can see that, like, it seems like your day is still out of order. Like maybe I'll refer you to like see a psychotherapist and an occupational therapist to try to get like your work back in order, try to get your schedule back so you can get back to routine, try to have someone talk with you about your thoughts and your mood and see if they can work with you in ways that can lift that up to where it was before your injury. But it really just depends on the doctor or the nurse practitioner's experience.
So interesting. So I just see a wonderful opportunity for kinesiologists to visit all kinds of nurse practitioners and physicians, right? To say, I'd love to manage any concussion patients that you have. And so here's my circle of influence. Here are all the different healthcare pros that I work with. We are a concussion management team, virtually, or a bricks and mortar team. And we would be happy to liaise with you if any patient experiences a diagnosis of concussion.
Yeah, that'd be awesome. That sounds like my dream career right there.
There you go.
I think. Yeah, I think that pretty well covers all this stuff. Let's see what we have. next. Here's a couple of tips and tricks to keep in mind when you're working with folks who have brain injuries or concussions. There's a running saying that if you've seen one concussion, you've seen one concussion, because like we've been talking about, they are so varied. There's obviously themes and trends as far as symptoms go, and some recovery times, or sometimes you can gauge them based on just where they're at off the bat. But when you've seen one, you've really seen one, and each treatment plan needs to be absolutely individualized and ready to be modified at any time, given their symptoms and how they're doing. Another tip is that concussion patients often have decreased attention, both attention span and physically just able to keep their focus on something at all. So when you're working with them physically one-on-one or virtually, or however you're working with your patients these days, keep in mind that they might zone out really easily. There's nothing, no fault to you. They just physically can't keep their attention or concentration, I think, long enough to get all your information in. So be prepared to repeat yourself, be prepared to explain things in different ways, use different modalities, whatever you think will keep their attention the longest, try that route. Your patient's personal goals should be at your forefront to your own planning. Oftentimes in ABIs and concussions more so, patients' goals, I feel, tend to be at the forefront, but often in ABI, if they're more severe, sometimes the goals of the practitioner or the doctor or their loved ones sometimes take center stage to what the patient themselves wants of their own recovery. And it's good to keep in mind that the patient you're working with is their own person, and that if they want something for themselves, you should try to push for that best you can, as long as it's a reasonable outcome or a goal you think they could work towards achieving, and not just if it's a lesser goal or a different goal that a family member wants for them instead. Do your best to focus on what the patient's needs are.
So interesting, because you're almost giving your patient permission to get the help they need. And sometimes if they are able to defer to a healthcare practitioner to say, my therapist of whatever background said, or, you know, they brought this to mind, so all of a sudden it's more okay to get the help because someone said you may need the following help.
Yeah, absolutely. And going along that help we mentioned a couple times is that folks with brain injuries, whether it be concussions or ABIs, it's seen in both frequently. They often have emotional lability or regulation, control. They might get agitated. They might have a lack of initiation to activities. They might just be low mood. They could, like I mentioned, start crying spontaneously. They could just start yelling, even though they don't mean to be angry and yell. That's just, they can't inhibit that ability to just do whatever they're thinking. Inhibition is a big one for brain injuries, especially ABI population. A lot of them lose their ability to inhibit their actions, words, anything they do is really that part of their brain sometimes just shuts off. Some other things, they might be forgetful as well. Kind of goes along with attention span. If you can't attend to something long enough to put it in your brain in the first place, it's unlikely it's going to actually sit anywhere long-term storage memory wise. So be prepared to have them write things down, to repeat yourself often, because they're not trying to not listen to you, but they just might not sit there the first couple times you say it. Some more stuff. Oh, go ahead.
Sorry, I was just going to say it might be interesting that you could keep in mind that you're presenting information to someone in different ways. So maybe you do a voice recording, or you take a photograph of something. You might send them an email or write something out. So you might look at delivering information in different ways, and then they'll be able to pick it up in whatever way it suits them at the time.
Absolutely. And I've seen a couple times in clinical practice, you'll see concussion patients come in and they're giving them exercises for their concussion or for other injuries they might have. And they ask them the next week, like, oh, how are your exercises going? And if it wasn't written to them on a piece of paper, it's like they never had exercises to do at all. So really try to get as much as you can in paper. If it means taking a picture of them on their phone in whatever exercise pose you want them to do, so they can reference it, do whatever you have to do to make sure they can remember and reflect on whatever you told them during your session. Goes along with the next point here of brain injuries. They often lead to a combination of communication problems, physical and cognitive impairments. So even the way you speak with them, on the unit that I work on, it's a neurobehavioral unit. So I see a lot of behaviors and a lot of mental health and cognitive impairments. And several of them have levels of aphasia. So they have speaking and word comprehension difficulties. And oftentimes they only understand a few words at a time. So if you want them to have a sip of their juice, instead of saying like, hey, have a sip of your juice, it's right here in front of you, you would just say juice, sip, and then that's the way the brain can understand, okay, juice, taking a sip, instead of just breaking it down as much as you can for them. The next point here is whiplash and neck injuries. We've mentioned this a couple times throughout the presentation that people who have concussions, it's hard to have just your head hurting without, like, it's really hard to get this motion going with your head without your neck being involved. So really make sure that you're able to treat the other parts of the neck, head, upper back, sometimes chest, that can be involved in a brain condition. That's not just the brain part. You want to make sure all the musculoskeletal stuff is cared for as well. And just be patient with people who have post-concussion syndrome. Like we've been talking about, if they didn't get the care right off the bat, their recovery time goes from looking like it could be a month to months and months and years. And these legacy patients that we talked about earlier, they very well could maybe never recover if they don't get the care that they need off the bat. And here's some ideas for further education. These are a couple of organizations that run concussion specific courses. CCMI is a really cool one because they have a very holistic approach to their concussion recovery. Shift and Impact are two others that also provide good concussion, fairly holistic measures of recovering for, they're more for physical stuff. CCMI touches a bit more on more aspects of concussion recovery than Shift and Impact are mostly musculoskeletal and more basic brain recovery than that one. There's also, you can do master's research in concussion if it's interested to you. There's a couple of masters of rehab therapy kind of programs. I think McMaster has one. There's a couple of college certificates, whether it's in, if you want to do it in something more specific, something more broad, and then apply it to brain injury. So you could do like behavioral programs. There's a couple for ABA and other behavioral practices. There's some for, you could do massage therapy and help in the other aspects of, and just get more training as a kin to get better with it. There's a program like the one I took at Mohawk, which is in brain disorders management, which gives you a little bit of info on a broad array of brain disorders. Everything from ADHD to Parkinson's is covered in this. If it affects your brain and body, it covered it at least a little bit throughout the course. I feel like
I'm just going to go back, sorry, to the CCMI Shift and Impact. Are those private companies? Are they affiliated with hospital groups or research centers?
Yes and no. So for Impact, it's Katie. I know her because she's best friends with a postdoc, with a doctorate student I used to be in the same lab in for York. So
she's a kinesiologist, or?
She's a physiotherapist.
Physiotherapist. And what's Katie's last name?
Oh geez, I forgot.
Oh, sorry. Put you on the spot.
Sorry, yeah. I know it's Katie. The first name's Katie.
That's okay, no problem.
Yeah, so her business is indirectly related to her research at Laurier and CCMI. It's almost like a little bit all over the place, like, you know, this clinic, that clinic, this university, that university. So they're private, but they have their little, you know, dendrites in different places. Exactly, right. Yeah. So yes and no.
I love that, the dendrites of connections. Very good. Okay, that's interesting. Yeah.
This is one slide that I think I skipped over earlier for the physical things. I thought it'd be interesting if anyone had questions as to what specifically KINs can do with people who have ABIs or concussions. This is not an exhaustive list, but a fairly inclusive list of things that can be effective with someone does have an ABI. If someone is curious into this realm and they're looking to see, well, what would I actually be doing with these people? Like, what kinds of specific conditions would I be helping them fix? And there's a bunch of them, from anything from paralysis. They might just have poor balance if their cerebellum was affected in their ABI or in their concussion. Just physically retraining their balance because they might just not know which way is up and down. You might be just working on their endurance, especially if they've had a severe ABI. They had some fractures of their legs or their lower body or their torso, and they weren't able to exercise. It might just be physically reconditioning them to get back to their old way of life. there's things such as they might have difficulties with planning movements, depending on if some of their frontal lobe or if they're more brainstem parts of the brain that are responsible for that loop of planning movements are affected. So you might just be helping them learn to cue when to do their movements until their body gets used to the actual flow of them again. Kind of with that goes poor coordination. General muscle stiffness is big, as well as contractures. And ataxia kind of falls into this as well, where a lot of people have really severe spasticity and their arms, legs might physically be stuck in this position, sideways, up, down, against their body. Their legs might not be able to straighten. Their hands might be stuck all bent. And that's a big thing. You can work with them and trying to build some more mobility, strength, some flexibility through all their joints that have this really, really, really stiff contracture through. And even just weight management is a big one as well. If you're used to having a really big, like really active lifestyle, then suddenly you go from super duper active to, man, I can't do anything. A lot of people experience either weight gain. Some people even have weight loss if they just don't have an appetite at all after their brain injury. So helping them manage their weight through their recovery process is a big one too that KINS can help with.
Do you know if there's any funding available through any groups for KINS to become involved in clinical rehab?
That's a good question.
I don't know offhand.
Yeah.
So in Windsor, there's a rehab hospital, Hotel Dieu Grace Healthcare, and they have an inpatient ABI program, and they do have a kin that works on that unit. I was able to shadow them for part of my placement in 4th year. But again, it's, you know, one part-time position.
Right, right. So I can see that this area would be becoming bigger, and the opportunities for KINS would be huge because we can reach from occupational rehabilitation right through to work hardening, work conditioning, and then into sport performance training. So all the way through activities of daily living, workplace, and then back into sport. So specializing in one particular area of rehabilitation or being able to provide multiple treatment planning services for a team would be a neat place for KIN to land, I think.
Yeah. Like I was telling Bridget weeks ago, like as KINS, we're in a very interesting spot, being regulated, which we have, you know, comes with its privileges, but also the scope.
Yeah.
So we have, we go through that exam knowing, have to know, be competent in many different disciplines.
Mhm.
And, concussion has many different
Dendrites.
issues. It's actually dendrites, yeah. So KINS are very well suited for concussion rehab. Many don't know that, but also many other healthcare practitioners don't know the scope of kinesiologists at all. I had one physio perform PNF on a patient, and he wasn't sure if that was within the scope of a kinesiologist to perform that. So, we do have to do a better job as a community, and the college has to do its part too in educating the public. Because, we can do manual therapy. We can use modalities such as, electrical stimulation, like muscular, of course, not deep tissue, laser, vibration guns, all sorts of modalities, and like it helps a lot.
Be really interesting to set up different kind of marketing campaigns around all of the core competencies of a kinesiologist. The scope is really broad, but if you then look at streamlined core competencies and almost had like a did you know rotation, and in concussion, in electrical therapeutics, and you just went through, did you know all these things about what a KIN can do down these rabbit holes, nutrition, return to sport, return to work, all of those kinds of things.
Yeah.
It'd be fun. It would be fun.
I
Thank
actually
you
have,
for this.
can I ask a question?
Yeah.
I just have a question about I don't know if I hope I didn't miss this earlier in the presentation or anything, but as far as like people getting tested for like their baseline scores ahead of a concussion. So like whether it's athletes, kids, or even the general population, like I guess what is being done and should it be done more? What are your recommendations as far as that goes?
Well, there is no gold standard for baseline testing. Like different practitioners have different methods. A lot of schools do one certain thing. Well, the SCAT-5 is pretty popular. You know, SCAT-4, SCAT-5. I think when I was in university, it was SCAT-3. So it does change. So the baseline testing is I think super important, especially for teens. Like the SCAT-5 on its own for baseline and post-injury is not robust at all. Like it's because, as we know, like concussion's complex. So we need different kind of testing. We got to test balance. We have to test cognition. We have to test ocular motor reflex. So it can be very complex, and there's a lot of research out there, and there's a lot of practitioners that make it, you know, like a battery, like a concussion, like a baseline battery. Like for provision, some of the things I do is like, well, first of all, we get the medical history. You know, like what gender are you? What is your family history like? Things like that. Like we said, ocular motor reflexes, like checking their saccades, checking their head movements, stuff like that, which is totally within a kinesiologist's scope. What else do we have here? I'm just looking at my notes. So we're looking at, you know, balance, all that stuff. So it can be quite robust if you kind of integrate research-based methods into that. One other thing is that, you know, just because they're asymptomatic doesn't actually mean that they're okay to return to play. So this is kind of new research coming out. So during my graduate work, we kind of dealt with that. You know, just because they scored fine on the bombs, right? So like their eyes, like the saccades are not eliciting any dizziness, stuff like that. Their balance is a-okay, stuff like that. Doesn't mean like they're good enough to be sent in as a right wing, right, midfielder, because there's a lot of stimulation. So we kind of, this is new research coming in where we have to kind of test sensory motor integration or cognitive motor integration. How do they think and move or perceive things and move at the same time, right? So you have, you know, visual stimulus coming from the left, and then you have you're holding your stick in your hands. So how does the brain, you know, comprehend all of those aspects? And with concussion, we know that concussed athletes aren't great. Once they're hit, they're not actually ready to go back. They're actually performing poor. So that's a new thing that therapists should consider. And as therapists, you know your patients the best. So you can see it with your eye, like they're not themselves. So it can be subjective, but they're starting to develop some more objective measures. So baseline testing, definitely super awesome and important, especially for teams, for athletes.
Yeah, I'll just piggyback onto that too. Like you said, I think it's really good if you could use a battery of tests. I had friends in high school who were football players, and they all took their tests every year as they had to, and through university and that as well. And they used to tell me, and since I got concussed the end of high school before I went to university, everyone kind of knew me as a like concussion reference person to like ask all their questions to. And they would tell me that they would, on their initial testing, they would just purposely mess up a couple questions. They would just purposely, you know, go a little bit slower than thought they had to in case they got concussed. That way they could still play. So whatever testing that you do with your athletes or whomever you're doing baseline testing with, try to bulletproof it as much as you can so that human influence as far as athletes wanting to get back to play, if it's a workplace one, make sure that they're, you know, the risk of losing their job or not be able to do that, it doesn't weigh on them, and they try to fudge their baselines. That way, if they do get an injury, it'll still show impairments, even if they try to, you know, fudge it a little bit the first time around.
Yeah, it's called sandbagging.
Yeah.
What's it called? Sorry.
Sandbagging.
Sandbagging, right. But you think about it, a lot of the people that are going through the pre-concussive screen, or the, you know, part of their preseason screen, their brains aren't yet fully developed. They're younger than 25. So
Yes.
this sense of logic that they have bought into is if they underperform during the screen, it gives them that buffer that allows them to return to play, when in fact it's very, very
Yeah.
important that they actually really do show up as clearly and cleanly as possible, so that we are protecting their most valuable organ. So
Yeah.
it's a bit of straight talk, I think, going into a season
Yeah.
with these athletes, to say, you know, you really do have to trust that this is in your best interests, and these findings, your possible future concussion could significantly impact the rest of your life. So please take this really seriously.
Yeah.
Yeah,
And
for
with
sure.
that-
Education is so important.
Yeah. And with that too, I think it's important to kind of, along with bulletproofing the testing for it, is to allow for things like over the course of a year, say they do their pre-testing in August and their season ends the end of the next year. If they're a young enough age where they're still, the brain's developing, they're learning, there could be just maybe the kids are physically just getting a little bit smarter over the course of the year. So they might be getting better. So if they do get hit, a little tiny difference might not even appear because they might have just physically improved up until that point before the season started, or postseason, or however long your season is. So make sure that it can allow for natural improvements in like just growth, and also for retesting purposes. I know a couple of my patients at the clinic, they would tell me, did the MOCA with them, and they were telling me like the 5 words that they got tested when they first got hit a year ago, because they got that same test so many times. They remembered the words from like 2 years ago. So make sure that whatever testing you do is also stand upable to just natural changes in someone's intelligence and their abilities over time, as well as retestable as far as not being able to repeat it by memory if possible.
Yeah.
It sounds like a lot of the tests are being done like with teams and things, and that's what like got me asking about it too, is because, you know, even for like the individual sports, I'm not sure that it's being done. Like for like my
Like
background is
boxing.
just in figure skating, so I know a lot about that, and I had several concussions when I was a young skater as well.
Yeah.
And I mean, back then, of course, it wasn't even heard of. It was just like go back out on the ice as fast as you can. But anyway, yeah, I'm not sure how much it's being done in individual sports and things.
It's
Even.
definitely a new thing coming up.
Yeah.
Yeah.
It's almost as if you would have to sell, quote unquote, your screening services to parents of those athletes, to say, you know, in the onboarding, in your fees for the year, part of the fee is going to go toward a screen, and that's going to be just part of your athlete participating for the season.
Yeah, because unfortunately, like parents can be part of the problem. Yeah, right. Like they want to hide their child's concussion, and which sounds crazy to me because from a parent's perspective, but they don't necessarily want people to know. So then, yeah, it has to be like a mandatory thing or something like that. But anyway, yeah, maybe it'll come to that.
Yeah,
Imagine
and I know for certain teams, it can depend on the funding they have. Like if it's like even like a varsity funding situation, like at U of T, for example, they have a 3-tier funding system for their team. So the, you know, bottom tier teams, they're not getting concussion testing, right? It's only kind of the footballs, the hockeys that are getting the testing. So anybody who doesn't fall within that, there's an exception of a couple of contact sports that aren't in the top tier funding that get it, just because U of T does a lot of concussion research itself, and they want to make sure their athletes, they use them as like guinea pigs kind of to track their symptoms and stuff. But yeah, like funding is a really big piece of it, right? So if we can find a way to kind of integrate that as kids and just as practitioners in general, and make sure it's a priority, I think that's important, because otherwise, yeah, people are just going to keep avoiding getting tested, fudging the tests. Like we all know people who avoided going to see a doctor, right? Unless you're called out to go, a lot of people won't go, or they might not even know, right? So yeah.
So wouldn't it be interesting that the colleges and universities with athletic therapy and kinesiology programs, what if kin students were taught about concussions and ABIs, and they actually got paired up with athletes. And so that kinesiologist had to test 5 or 10 athletes, which gets the job done for the university at no cost, but then also helps to build the AT and the KIN programs as well.
That would be interesting. Like I know at U of T, like I did a field care placement where I was like a student therapist, what we were called. And part of that was running sideline scats and whatever else we were doing in the clinics. But it would be interesting if they could integrate that in that way to kind of make sure that everyone's accounted for and for that kind of learning experience for the students as well.
Mm-hmm.
Yeah.
Interesting. Thank you very much. This has been super interesting. Does anyone have any questions rattling around in their healthy brains? Hopefully healthy brains. Thank you for this. We will post the recording, the link to the recording in the group so that you'll find it to reflect back on our YouTube channel, and you can review this and take notes and think about any other questions that you have. And you're welcome to come back into the post tomorrow and just jot down any other comments or questions that you have so that we can get back to you. Well, the royal we, Andrea and Bridget, can get back to you about any of your questions there. So
Thank you so much.
Yeah, thanks so much. I really appreciated your presentation. Yeah, it was fantastic as always, Carrie. I think, we've got, sorry, Carrie, I missed your comment there. It's not done much in gymnastics either. Yeah, for sure. I think there's a lot of sports where it's just not considered. So interesting area for KINs anyway. Thanks so much, everyone. And you'll see the recording tomorrow. And as always, let me know if there's any other follow-up presentations or questions that you might like to have based on this topic or any other. Thanks again. Have a lovely evening.
Thank you so much.
Thanks.
Bye for now.
Bye.